Hi, I'm Dr. Mahadevan, Professor of Medicine and Director of the UCSF Center for Colitis and Crohn's Disease. Today, I will be talking about the pregnancy paradox, how stopping medications in pregnancy to protect the fetus can actually lead to greater harm. These are my disclosures. So let's start with talking about the penalty women pay in many ways for having the ability to produce a child. So in 1977, the FDA policy recommended that women should be excluded from phase 1 and early phase 2 drug trials if they had reproductive potential. This was regardless of whether they were on contraception, single, or even had vasectomized husbands. In 1986, the NIH policy changed to encourage researchers to include women, but this was poorly communicated and not followed. It was only in 1993 with the NIH Revitalization Act and Dr. Bernadine Healy, the first woman director of the NIH, that women and minorities were encouraged to become part of clinical research and recruitment was actually monitored. There's also the misuse of FDA labels. We all remember the A, B, C, D, and X labels, which went away in June of 2015. These labels were often misused to deny therapy for women during pregnancy. A good example is azathioprine. Though human data showed no harm because it had a label of D, many obstetricians would not care for my patients if they continued their azathioprine. The PLLR, or the pregnancy labeling rule, began on June 30th, 2015. And now we have more informational labeling with recommendations for us to follow and not a category. So you'd think, well, we're a long way past that, right? Well, unfortunately, that's not the case. What happens today? Women who are pregnant must drop out of a clinical trial, even if it's for an agent with known safety in pregnancy, for example, an anti-TNF or an IL-23. Women of childbearing potential, not pregnant women, but women who could get pregnant, are often not given Jacobins by their providers in case they get pregnant by accident. Animal studies have shown risk at supertherapeutic doses, but we have very limited data in humans. Medications with well-established safety records like anti-TNFs are often discontinued in pregnancy. In fact, 68% of women who stopped an anti-TNF during pregnancy said they did so on the advice of their rheumatologist. And then most recently this week, the European Medical Agency came out with a letter that said that infants exposed to infliximab in utero cannot receive a live vaccine for 12 months. And that if a mother is breastfeeding on infliximab, the infant should not get a live vaccine, regardless of age. This is clearly very harmful to the infant where vaccines are needed and makes no logical sense based on significant available data. But it just goes to show that there's a lot of fear when addressing pregnancy and women and their infants, and that fear drives decision-making as opposed to actual data. This was a national cross-sectional survey of Canadian rheumatologists. On your left-hand side, you see what percentage of them continued these anti-TNF biologics during pregnancy. And then along the horizontal axis, how long they were continued. So 76% continued infliximab, but only 40% of those continued through to term. So you can see that despite adequate data showing safety, there is still a lot of discontinuation of biologics in pregnancy. So what does the AACR recommend? This was published in April of 2020, and they said we conditionally recommend continuing tumor necrosis factor therapy with infliximab, etanercept, adalimumab, or golimumab prior to and during pregnancy. As certolizumab does not cross the placenta, we strongly recommend continuation of certolizumab prior to and during pregnancy. The kicker is in red. The voting panel agreed that if the patient's disease is under good control, these medications may be discontinued in the third trimester. And I would ask why? And how do you know their disease is under good control? So how do pregnant women with rheumatoid arthritis do? This was a retrospective cohort study using the national inpatient sample, and there were over 8 million births, of which 6,000 had rheumatoid arthritis. Women with RA were more likely to develop preeclampsia, eclampsia, gestational diabetes, preterm rupture of membranes, placenta abruption, placenta previa, and need a C-section. Postpartum, they had more wound complications and thromboembolisms. And then among neonates, there were more birth defects, small for gestational age, and preterm birth. So how much of this is due to disease activity, how much of this is due to medications is unclear because that was not measured in this study. But I would argue that many of these outcomes, including preeclampsia, premature rupture of membranes, et cetera, have to do with inflammation because we see that in inflammatory bowel disease and have documented it very consistently. Okay, but the argument I get from rheumatologists is threefold. One, rheumatoid arthritis gets better in pregnancy. And I would argue, show me the data. The largest study I saw had 118 patients. And one paper I read actually started by saying, as we all know, but not showing any data. So it's truly based on personal experience and bias and not high quality studies. There was actually a German claim study that showed reduction in treatment during pregnancy and that many women did not return to pre-pregnancy treatments after delivery despite signs of disease exacerbation. A second argument is my patients don't want to take medications during pregnancy. Well, that is twofold, and it's clearly been shown in other disease states, including IBD, that one part is education. And if you educate the patient on the safety of medications and the risk of disease exacerbation, they will continue therapy. The bigger part is provider bias. The people who don't want medications in pregnancy is more the provider than the patient. And then finally, well, we can just give them steroids. And here I would argue that steroids cause more complications than anti-TNFs. And I'll show you some data to support that. It includes gestational diabetes, increased disease flare, and even congenital anomalies. So I would argue that the significant increase in pregnancy and neonatal complications that I just showed you that occur in rheumatoid arthritis pregnancies is likely closely linked to disease activity and inflammation. Stopping low-risk and effective steroid-sparing therapies lead to increased suffering for the mother, postpartum flares, and worse outcomes for the baby. So then I have to ask, who are you helping by stopping the biologics? So let's go to some lessons from gastroenterology. So I am the principal investigator of a national prospective registry called PIANO, Pregnancy Neonatal Outcomes in Inflammatory Bowel Disease. And in our paper that was published in 2021, we presented the results of 1,490 women, 379 on no medications, 200 or no thiopurine or biologic medications, 242 on thiopurines, 642 on biologics, and 227 on both. There was no increase in birth defects, spontaneous abortion, preterm birth, or low birth weight, or infections in the first year of life. However, when a baby was preterm, there was an increase in infections. If there was active disease, there was an increase in miscarriage. And none of these medications led to a negative impact on developmental milestones. We also show that corticosteroid use in pregnancy is associated with adverse events. This was published in Gut this past year. So we did show that infants exposed to steroids in utero had higher rates of preterm birth, small for gestational age, low birth weight, and intrauterine growth retardation growth restriction, as well as NICU stay at birth. You can argue that all of this is associated with disease activity, but we also showed that infants who were exposed to steroids in the first trimester had a statistically higher risk of congenital malformation. We did not see that with disease activity exposed infants on biologic therapy. What about infections after fetal exposure to biologics and thiopurines? Out to 1 year in these 1,431 infants, there was no increase in infections by drug of exposure, whether it's biologics or thiopurines. There's data outside of PIANO from TREAT, from Evasion, TEDDY, and DUMBO. These are mostly retrospective, large-scale European studies, with DUMBO being a prospective Spanish registry. They showed the same thing. And what they also showed is when you stopped a TNF before week 24, you had an increased risk of disease flare. This study from Canis looked at 1,000 children born to 626 IBD mothers, and again showed no association between anti-TNF exposure, thiopurine exposure, and the adverse events listed, including adverse reactions to vaccinations. There was an increased risk of intrahepatic cholestasis of pregnancy with thiopurine use. This large retrospective French study using the French National Health Database showed that if a mother was on anti-TNF in the third trimester, they may have an increased risk of infection. If they had severe disease, they may have an increased risk of infection. But if they stopped their TNF and had disease relapse in the third trimester, that is when we saw an increase in child infections. So stopping the medication led to a flare and led to increased adverse outcomes for the child. What about breast milk? So we published our data looking at the amount of biologic in breast milk, and the amount is truly negligible. And there was no increase in the rate of infections or developmental milestones or infant growth at 1 year based on breastfeeding and based on drug of exposure. Response to vaccines also was not harmed by exposure to biologics or thiopurines compared to those unexposed. Now, what about live vaccines? In the US, we recommend that if you're exposed to a biologic, you not get live vaccine in the first 6 months of life. And in Piano, there were actually 43 patients who received rotavirus vaccination within those first 6 months, despite exposure to an anti-TNF. And those babies actually did quite well. So not giving live vaccine in the first 6 months is probably overkill, but we still recommend it. However, the EMA recommendation not to give it within 12 months or in infants who are breastfeeding and the mother's on an anti-TNF is really incorrect and harmful to mother and infant. Achievement in developmental milestones was the same regardless of drug of exposure, and actually anti-TNF exposed infants did better than the other infants. And then finally, daycare. Again, our European colleagues recommend that if a child is exposed to a biologic, they not go to daycare for a year, which is great if you're in Europe and have a year of maternity leave, but in the United States, that's really not feasible. So we did look at whether going to daycare led to higher infections among biologic exposed infants, and the answer was no. Whether you went to daycare or not, you had more infections, of course, but that was not impacted by what drug the child was exposed to in utero. So I will end by saying that if you think rheumatoid arthritis does not have negative effects on pregnancy, you're incorrect. If you think that biologics are harmful to pregnancy, then there is the accumulated data do not support that. If you stop a biologic in a mother with rheumatoid arthritis, you may actually be causing more harm to her and her offspring than if you continue. I will end by saying healthy mother, healthy baby. Of course, more data are always needed, but think carefully and monitor your patient carefully if you're going to discontinue medications. In gastroenterology, we continue it throughout pregnancy and lactation. Thank you.